All right, folks, thanks for being here. We're going to go ahead and get started. Thanks for joining Disability Rights Montana at our Tuesday session, talking about the behavioral health system here in Montana via the lens of the Montana State Hospital. And tonight we have our staff attorney, one of our staff attorneys, Mike, to walk us through what's going on, how things work, and um, how things are going right now. So take it away, Mike. Thanks.
Well, good evening, everyone, from Disability Rights Montana in snowy, cold Helena, Montana, presumably cold and snowy wherever you are as well. Again, my name is Mike Lahr. I am the staff attorney here, and the presentation I would like to give you tonight is basically very much of an overview of the behavioral health delivery system in Montana. In the little blurb that was sent out, I promised a Leonardo da Vinci um, reference, and so I will get to that first and last. And first, we, of course, in our modern age with satellite imagery, we take the concept of bird's eye views and satellite mapping. Um, it's matter of course. We don't even think about it. But going back to the time of Leonardo da Vinci, it was a new thing. No one had ever even thought of it before. And I like to think that it was Da Vinci's love of birds that gave him the idea. And so during one of his various uh, times when he was working for princes in Florence and Milan, he also worked for a prince who did not last very long in Imola, a city in Italy. And it came to him that he could walk the city, take measurements, use his keen observation skills, and essentially draw what would be an overview or a bird's eye view of the city of Imola. And to this day, it is considered the very first bird's eye view representation of a city. I am not Leonardo da Vinci, do not have his skills or talents, but this will be my Imola concerning the behavioral health delivery system in Montana to give you an overview of how things work, how they fit together. And because so much has been in the news in the last several years about Montana State Hospital, I thought I would begin there and work outwards. And I think the state hospital is not only a very important piece of the delivery system, one could say that things begin and end there in one way, shape, or form, but it is very illustrative of all of the issues that you will hear about in the news going on at the legislature. Not that everything is focused on the state hospital, but all the different recommendations, for instance, that have been made in the Future Generations Plan, many of the debates, be they about Medicaid expansion, be they about waiver programs, appropriations for facilities, trying to develop incentives to attract a stronger workforce in the behavioral health field. All of them can be illustrated quite well by starting at the state hospital. So that's what I will do. Uh, the first thing I would like to mention about that to sort of give an overview to the overview or place everything in context is we have a date in Montana in connection with the state hospital that it's one of those, there are things before then and then everything that has occurred since then. And that very large, memorable event was the decertification by the Centers for Medicare and Medicaid Services to decertify the hospital and take away Medicaid funding. And that period of time from the first warning to when decertification actually occurred was from March into April of 2022. This, of course, was following COVID-19, several disasters that occurred. There were a series of falls, of deaths. Uh, there were just many bad things that occurred at the hospital during that time frame, ultimately resulting in a final CMS survey, which said this is unsustainable. And so the first thing that happened that many people forget is that it was a warning. They didn't immediately say, we are withdrawing all funds. Uh, they wanted to set up kind of a probationary period, a work improvement plan for the state hospital. And the idea was that CMS would have its surveyors and technical expertise, and it would essentially have someone at the hospital all the time with other people coming in and out from their offices across the country to provide expertise, technical skill, administrative skills to get the hospital back where it needed to be. And then suddenly, there are a few more things occurred which were not good, which simply proved CMS's point that things really are going wrong at this hospital. And suddenly it was over. The work plan, the probationary period, all that went away. And in discussions with stakeholders, CMS indicated that there were two primary reasons for that, that they simply decided to withdraw. The first thing was they noted we have a lot of expertise. We work with hospitals. Uh, we know what we're doing. We can improve clinical programs. We can improve administrative efficiency. We know how to develop training programs. We can dig in and work through policies and update them. We can do a lot of things, but there are two things that they saw as insurmountable in Montana. And the first of those was they saw no end to the workforce difficulties faced by the hospital. At that time and to current day, a good majority of the staff has been the so-called travelers, traveling nursing staff, traveling CNAs. Um, and they saw that there was no way out of that, that it was sort of a spiral that the state hospital simply would never be able to recruit enough permanent staff and keep them on staff uh, to really make a difference. And with that, they saw that constant training and in addition to the constant training, the lack of continuity would just be a problem that would continue on into the future, which was not an administrative thing. It was just a sort of systemic flaw in the hospital's work that would continue. The other thing that they recognized, unfortunately, was something that they saw as, again, another structural defect, if you will, that would be insurmountable and would require regulatory changes, legislative changes. But that had to do with the so-called you can't turn off the spigot problem, was that in order to get the hospital back to where it needed to be, CMS simply believed that at some point you are going to have the ability to limit the number of admissions. You somehow have to be able to get ahead of things. And that the way it was currently structured and the obligation that the state hospital has under law, that you were simply never going to get to that point. So based on all those reasons, or based on those two primary reasons, CMS decided to give up at the earliest stage rather than try to cure something that it felt it simply did not have the wherewithal or the ability to do. So that's what brings us to this date. So since decertification, obviously we've gone on 3 more years since then. All of us somewhat shocked to think that with the loss of Medicaid funding, that the hospital would could keep its doors open. Initially, when all this was going on, you may remember people were panic stricken of how will we find placements for everybody, what kind of arrangements can be made. As it turned out, the hospital has been able to limp along minus the Medicaid dollars with more expansive general fund dollars, keeping things going. But with all that background in mind, I wanted to talk about three different places, the main three places at the hospital. And that has to do with, first of all, the Spratt unit, and then I will talk about the main hospital and what that looks like and the work that is done there. And finally, to talk about Galen, which is approximately the forensic mental health facility located about 5 miles from the main campus in Warm Springs. And Spratt is important for many reasons. And I just want to provide a little background for what it is, what it looks like. But from there, again, as I said, kind of zoom out because it illustrates very well certain concepts and commonalities that go across the board in the behavioral health delivery system. So, Spratt is known as the geropsychiatric unit. So, the first indication there is right in the name, primarily a geriatric population. And it is a separate building away from the main hospital. It's on the main hospital campus, but it is its own standalone building. It's a large T-shaped building with the cross of the T being the resident bedrooms. And then the leg of the T is common areas, cafeteria, laundry, bathrooms, that runs all the way down and then ends with staff offices and the pharmacy. It is a facility because it is long in all directions, and there are nursing stations at one end and then at the other end. It is not the uh, best physical situation for observation. There are places where the residents of Spratt are often off to the side and not in easy line of sight for staff that may be closer to the nursing stations. In addition to that, the distances are fairly great. So, one of the things that was occurring with disturbing regularity before the CMS decertification occurred was the number of falls. And unless there is the so-called one-to-one, meaning that there is a staff person who is at all times at arm's length, if not right next to the individual, people are going to fall, people are going to have difficulties, and it may take a bit before staff can intervene. So those are some of the problems in general with the physical location. But on top of that, again, by the name, the geropsychiatric unit, Montana, like just a handful of other states, um, has a blended population on the Spratt unit. By blended, I mean there are people who have organic disorders, neurocognitive disorders, think of Alzheimer's, dementia, that are co-located in the Spratt unit with others who have purely psychiatric issues. Um, so this blended population means essentially that you are treating individuals there or the entire population with two levels of care. It is part long-term nursing care and at the same time intensive psychiatric care. And those are issues that have been recognized to be problematic. And I will cite to a report later on, but that indicated that other states who do this often break the units up into different teams or divide the population in some way so that the levels of care and the staff that is working can be more directed, more focused on one population or the other. Uh, the Spratt unit has 60 licensed beds, and in recent memory, it has always been at or close to that, sometimes lower, depending on how they are doing with the discharge process. But there are a lot of people there. It has been pointed out in this 2020 study, staffing was an issue, staffing morale was an issue. Um, Many problems associated with Sprat. What I wanted to get to, sort of the first concept that goes across the board, is the one that has to do with, to explain it, is to begin with something that occurred in the 2023 legislative session, which was House Bill 29. And essentially, with all of the issues that were occurring at Spratt, um, the an interim legislative committee determined that we can do better. Is that too many? There are too many deaths on Spratt. There's too many neglect situations that occur on Spratt. It is not a good place. Again, as a state, we should be able to do better. And in getting through the legislation, it was designed, in very simplistic terms, to do two things. It was, first of all, designed to prevent people from ever having to go to the Spratt unit, to avoid commitment to the geriatric unit at Montana State Hospital. The terminology used, and which is used elsewhere as well, is to divert people from the state hospital before they get there. The second thing, of course, was there must be a way that we can hasten the departure, the discharge of people currently at on the Spratt unit, to get them to facilities back in communities, to find places of less restrictive nature where they will be better served. So, with those two general principles in mind, again, that is a common theme, whether we're talking about any institutional setting, is what can we as a state do to better prevent people from ever having to be institutionalized? But if they are institutionalized, what can we do to better discharge them? What can we do to get them into care in communities which will be most beneficial to them in a less restrictive setting, and hopefully ensure that they do not have to return to an institutional setting? So you have the front end or the back end, or said another way, you have upstream versus downstream. But that is a common theme throughout most of the facility related questions that we face in Montana, whether it be at the intensive behavior or Lewistown or the state hospital. Is we need to find better ways to keep people out of the institutional setting first, and we need to find a better way to care for them once they leave. Again, this moves on to the second concept that I would like to talk about, that is a common refrain, is these are all very good ideas, but getting from point A to point B is always the problem. And a good example stems from the ideas that have been put forward in the last several sessions, to where can we better place individuals with dementia or Alzheimer's so that they're in community settings, closer to home, hopefully getting better care in a small, less institutionalized setting. And so one of the ideas that came up was, we have assisted living facilities in Montana. They are categorized A, B, and C based on the levels of care required for the individuals who are in those facilities. Let's add another category that can deal with the dementia patients, those needing more care, more complex care, and may need to be kept secure in locked facilities, or potentially even seclusion or restraint may be needed on a limited basis. So we need some kind of step down, as it were, from a place like Spratt. How can we develop those in the community? So the idea was Category D facilities. They would be sort of this highest, most intense level of assisted living facilities. No one was opposed to it. It was a good idea. But again, the issue came, how do we incentivize people to actually open these facilities? And it is still a concern to this day. And in fact, though Category D facilities were created by law in 2017, there's not been a single Category D facility that has opened. And there are reasons for that. And what this points to is uh, we are often concerned, certainly here at Disability Rights, legislators, Board of Visitors, the hospital itself. Everyone is always concerned with the care and treatment and health issues, risks, potential abuse, neglect that occurs at the hospital. But much of what we are focused on with the behavioral health delivery system is not what occurs at the hospital. It's what is not occurring in the hinterlands. It's what's not occurring in our communities. Everyone can recognize that a filled to the brim institution is not the best place for anyone. Everyone agrees that people need to be discharged more rapidly into better care. Point is, the question is, the great difficulty has been for years, as I will get into later in this presentation, is how do you build up that infrastructure in communities as places for these people to go, whether it's in group home settings, assisted living settings, nursing facilities, or if they don't need that level of care, how do you provide the necessary supports, whether it's to help people get proper medications, whether it's peer support, whether it is respite care for families if they're returning to their homes. All of those things are necessary to fill out the system. All of those things represent currently gaps in our system. And those are the challenges faced by the legislature and providers in our communities, is to develop, to strengthen that entire system, which is definitely lacking. So to return to Category D as sort of a microcosm, or as an example of how this works, again, Category D facilities, great idea. Better, certainly better there than in the Spratt unit. But how do you convince people, providers who may have an existing assisted living facility, how do you convince them to take the risk with patients who do have these complex care issues, who may have, in additional to their neurocognitive difficulties, have physical health issues, um, and may represent a potential risk of harm to themselves or other residents. There is not a lot there to make people leap to the fore to say, I want to open one of those facilities, especially the way things are set up. There not a lot of control. There are initial outlays, costs of adding things to your facility that you don't have to have if you're A, B, and C, but you might have to have if you were Category D. But the primary difficulty has been whether folks are leaving Spratt to go to a nursing home, an assisted living, or ultimately potentially a Category D if they ever exist, is what is the financial incentive? You cannot pay people rates that you would pay the more traditional residents of these facilities if they are coming out with the complicated care requirements coming out of the state hospital. So there has to be a recognition that enhanced rates are required, at least for some period of time. There may be some initial cost coverage through block grants or other other mechanisms that would allow people to actually take the risk because they know they are not going to take a financial beating, and to give them some control over residents that do come their way, that if they find that they can no longer provide the level of treatment or it's simply unable to do so, that they have some kind of recourse and that they aren't locked into something that they're simply not capable of doing. All of these things, I must say, through the House Bill 29 Transition Review Committee, steps in the right direction are being made as far as providing these enhanced rates that recognize complex levels of care, and that these assisted living facility or nursing homes are going to need additional staff, additional services available, additional skills related, may need upgrades or improvements to their facilities to take on these residents, these patients from MSH. And so this whole idea of we need to incentivize providers is an important one. And again, it's across the board. It is the same on the developmentally disabled side. It is the same for group homes that may be taking forensic patients out, or even when you look at pre-release uh, homes activities, it's sort of again, a common thread throughout this is how do we take care of people once they get out? You can only do so with a fairly significant investment in both services as well as residences for people who need it. So that is, I wanted to talk about, you've got front end, back end, you have getting from point A to point B, and this whole concept of incentivizing people to take on the responsibility of care for people currently at the hospital. I want to move from Spratt then to the main hospital, and that is maybe a couple of hundred yards away from the Spratt unit, maybe 300 yards. Uh, it is sort of an X-shaped building. It is a relatively new building that I think was opened in 2001, if I'm not mistaken. It is a building, as I say, it's an X shape, so you have essentially four different wings. You have Alpha and Bravo and Delta and Echo. And interestingly enough, back before the new hospital building was built and opened, back in the 50s and 60s, and I believe even into the 70s, uh, what unit you were on, where you were housed, was basically based on what your hometown was. Before they decided to group people according to their diagnoses and their acuity level, uh, the idea of the hospital was very much about the return to your home community, be it with family or somewhere in the vicinity of where you came from. So there was essentially an east wing or east unit, central and western unit. And so it was the geographic location from which you came. That was the deciding factor of what wing you would be on. As clinical and treatment programs developed, they realized that that perhaps wasn't the most advantageous system, and so have changed it again to you are placed on a particular wing based on your situation and your diagnoses and your acuity level. And that's basically how it is set up today. But the main hospital wing, or the main hospital building and these wings, are people that are civilly committed. Now, that's not to say that the folks with neurocognitive disorders are not civilly committed. They are. That is how you get to the Spratt unit. You go through the same commitment process that others go through. The main hospital, though, unlike the population of Spratt, which again, primarily geriatric, those 60 beds at the Spratt unit, those are geriatric patients, although some may have psychiatric issues, some may have neurocognitive issues. Essentially, when you get to the main hospital, everyone that you are treating there has has mental illness. There may be some older folks there, but generally they're younger people, and but they're all being treated for psychiatric uh, for mental illness. So it makes it a little bit different. It is also different because whereas many people in the Spratt unit, because of the difficulty in finding placement because of their complex care needs, the sort of the rotation, if you will, of people in and out of the main hospital, out of the units, is much more rapid. Initial periods are for 90 days, and then people can be extended for 6 months and so forth. But these people are being rotated in and out of the system on a much more regular basis, which doesn't mean that discharge is easy, and discharge remains one of the biggest concerns that the hospital has, and that I think certainly disability rights has, and that I think the legislature has, is there are questions when you are trying to open beds, when you have sort of reached the limit of what you can do for individuals. By by law, they have to be released. But the question then comes, but where do we release them to, and what kind of care will they get afterwards? In a perfect situation, they might be released to a group home, have quite a bit of stability, have a roof over their head, have the opportunity to get a job and uh, segue back into normal life. Others will be able to go back home and be with their families. Others, however, just end up in shelters, and very often because of their mental illness, because they may go off medications, because they may have substance use issues, um, will end up homeless. Most of them will leave Montana State Hospital and not have any means of transportation. They will find themselves knowing that they need continued help, knowing that they need access to services, but unfortunately, finding access to those services, getting to where they need to get to, either to replenish medications or to participate in counseling or therapy sessions, they simply can't. And so they end up on the street, even if that's not where they were initially discharged to. And the cycle begins all over again. And that is, unfortunately, a very common problem. By no means do I wish to insinuate that it is a revolving door. It is not to that extent, but all would have to admit that there are many people at the hospital who have been there many times, or at least several times, and do go through this cycle, this sort of recidivism of uh, being restored, as it were, at the hospital, going back out into a community, and then ultimately 6 months, a year and a half later, find themselves recommitted to the hospital to go through the entire thing again. Once again, this common theme of we know people need to get better services once they are discharged, and we know that there are ways to keep people from being committed in the first place. We can have community programs that, again, catch people before they have to have an intense crisis situation. We need crisis stabilization services, but we need things before then. We need to be able to provide, whether it's through peer support, telehealth, uh, whatever is required to keep people or help people stay on a more level path as they return to their communities, is something that the state, unfortunately, is woefully lacking in. One of the things that, or two of the things I wanted to talk about that go directly to the behavioral health, the future generations, is two things that I think, well, there are multiple recommendations in that report, 22 primary recommendations, near term initiatives as well. Uh, But one of the things they talk about is case management, targeted case management, and especially when it comes to transition services. And that's really what one of the most important things that we're talking about here is that not to say that discharge from the state hospital can be haphazard, but suffice it to say that it is inconsistent at best and that it depends on the situation and the person as to whether they will have good access to necessary services in the community they're discharged to at the outset, or whether they will fall through the cracks very quickly and end up on the streets or in jail. Um, Much of that depends on the types of services that are available in communities. And one of the things that is talked about in the next generation, which I think is extremely critical, is case management services and targeted case management, and especially at points of transition. And what this really refers to, you may hear of this in the news or following the legislature. Basically, case management services, case managers are the people who are the navigators, as it were. They're the people with have the keys to unlock all the doors that can access the necessary services through different caregivers in the communities across Montana. They are the people with the expertise that can, number one, recognize what services are necessary for a particular individual, who the providers are that can uh, provide these services, also work on funding mechanisms to basically assist these people in getting the necessary services that they need as soon as they leave an institutional setting or leave jail. Or the other place that is vitally important is people going from child services to adult services. At each of those points, case management can be absolutely critical, something that needs to be bolstered. Beyond that, then, okay, it's wonderful to have case management services, but of course, the broader question is the this idea of the continuum of services. And much of the funding that is allocated and that ties in with these recommendations is again to build these services within communities so that people can get medications, so that people do have transportation that they can get either to work or to primary caregivers. Another uh, aspect of all of this is the integration of behavioral health with general health, is finding ways that people can essentially get one-stop shopping. That if they get to a primary caregiver, that the same location, they may be able to talk to their therapist, that they can deal with their behavioral health issues along with their general health issues. All these things are wonderful concepts, and as you will hear a little bit later, are not new concepts. But finding the funding is always going to be a difficulty. Um, the final thing that the next generation report focuses on is something that I've already talked about in relation to the state hospital. Employment. I will take a sip of water. The employment issue, workforce issue, staffing issues aren't unique to the state hospital. They have certainly been a problem there, and CMS, as I said, recognized it as perhaps an insoluble one over time. But as anyone who works as a provider, whatever, whether assisted living, nursing home, on the DD side, doesn't matter. There is a shortage of healthcare workers across the board. Hospitals all face it. Clinics of all shapes and sizes face it. Um, it is simply a problem that is a nationwide problem. and certainly cuts across the entire healthcare sector in Montana. Uh, Recent statistics through the Department of Labor have said that the need for basic healthcare providers, personal care assistants, home health care, that number will stay at around 2,000 uh, placements that are needed every year, meaning in the state of Montana, we need at least 2,000 new care providers every year. Well, for a state like Montana, that's a pretty large number. What's shocking about it is that it is potentially almost 80% of those placements are required because of turnover. People simply are not staying in these positions. Um, uh, Other statistics have been cited that with most providers indicate that they lose 25% of their staff every 6 months. Again, part of the reason CMS thought this was unsustainable, especially in Montana, where wages are uh, quite low, and many of these communities do not have the so-called draw that would keep people there. Um, it just exacerbates this situation. So, again, with the Next Generations report, the recommendations, there is a recognition that workforce is going to be one of the greatest obstacles to building up community services across the state. We see it as a problem at the hospital, but the hospital has the funding that, if necessary, as it has shown over the last 3 years, it can continue to pay travelers quite large salaries as compared to permanent staff, although that is beginning to balance out. Uh, but it is adds to the tremendous cost of institutionalization in Montana. But unfortunately, when you go out and you're talking with either for-profit or nonprofit providers who are beginning or trying to start, as it were, potentially a Category D facility or another assisted living facility or group home, finding staffing is just very difficult. And another thing that we are seeing is in various facilities that in different times have had much more bed space or beds available to take people out of institutional settings. They simply can't find the staff. So they may have the potential to take on more people, but they simply don't have the wherewithal to be able to, excuse me, don't have the wherewithal to be able to hire staff, keep staff. And so they keep their numbers, their occupied beds, as it were, down at a lower level. So the workforce issues, the workforce issues um, flow right into the continuum of care. You can have good plans, you can incentivize providers to enhance the continuum of care across the board, from very intensive to down to, for instance, peer support. Uh, Unfortunately, if you can't find the people, you simply can't man the facilities, you can't man the group homes. And then you have the additional problem of when it comes to the uh, uh, mental health professions, be it psychiatrists, APRNs. Once again, Montana is lagging behind, again, partially because of our rural slash frontier nature and wage scale. Is we're having difficulty not only in our state institutions, but across the board being able to attract and retain highly skilled mental health professionals, which are needed. They're one of the essential engines that keep the whole thing going. So again, a myriad of problems. We all have the concepts down. We know that what goes on or doesn't go on outside the state hospital is just as important as what's going on inside the hospital. But we lack the people, we lack the resources to generate this more in-depth uh, delivery system for behavioral health. The last thing I wanted to talk about then was sort of the third big piece of the state hospital, and that is Galen. And uh, don't want to get in too much depth, but one of the things that you will be hearing on the news, one of the things that's being debated at the legislature is what do we do with Galen? Again, we know that there are the 54 some odd beds at Galen. It is again a forensic mental health facility, and that means it's connected, intertwined with the criminal justice system. And the main reasons that people would be sent there are, of course, within our criminal justice system. Uh, Before you can be tried, before you can enter into a plea agreement, the court has to be assured that you are fit to proceed. And that simply means that you're capable of understanding the nature of the proceedings against you. You can assist in your own defense, meaning that you can work with your defense counsel. You understand the ramifications of decisions you make, of benefits of going to trial or not going to trial, that you can assist with developing your case. All of those things require a level of mental fitness that the court needs to be assured of before it will go forward. So the first thing that has to be done is an evaluation to determine is this person fit to proceed. If not, the next thing that has to be done is the person needs to be restored, if possible, to competency so that he can assist in his own defense. That may take a short time, it may take a while. Those are the things that Galen is involved with. The psychiatric staff there is basically set up as a supplement to the criminal justice system. If there is a question about someone's mental fitness, their ability to stand trial, the idea is they will be sent to Galen, they will be evaluated there. And if they are not fit, Galen, through medication and therapy, can restore them to fitness so they can go back and face the charges back in the community from whence they came. That, in a very simplified nutshell, is what occurs at Galen. There are other things that go on there as well, but which also take up bed space. If mental illness is a factor in the case, someone may be sent after they have been convicted back to Galen to determine where would they best be served, either at the state hospital or at the state prison. What kind of level of care may be needed for these folks, and so a kind of a post-conviction evaluation may occur as well. At any given time in Montana, there are between 80 and 90 people who are waiting to go to Galen. What this means is that they are sitting in a local detention facility um, without proper mental health treatment available to them. Again, simply waiting to get to Galen. There's been some question raised as to their fitness to stand trial. Uh, but while they wait for that initial evaluation and potential restoration, they are in facilities that, as anyone who works in detention services could tell you, as any sheriff in Montana would be quick to let you know, jails are not designed to take care of the mentally ill. They do the best they can. They've been forced to, certainly over the last 10 years. Statistics indicate that our prisons and jails, the population at any one time, 40% of the inmates are people who suffer from some form of mental illness, whereas the rest of the population is around 18%. So obviously, it is a significant issue. It is growing uh, by the day. We have far more people entering the criminal justice system with mental illness than ever before. You add substance abuse issues, concerns on top of that. On top of that, what it means is that you have local jails, people who are not trained and may not have the resources to get much mental health assistance in their local community, dealing with people who should be at the Forensic Mental Health Center in Galen. That's where they should be. Instead, people who are clearly in need of maybe intensive mental health services are in a detention facility. There are so many things wrong with that from a moral, civil rights, due process point of view, but it is a problem that must be addressed and quickly. And that is one of the things that the legislature is dealing with. One of the first ideas is, can we do these evaluations in the jails or do them locally? There are benefits to this that are fairly obvious. First of all, until people have their initial evaluation, we have, again, let's just say these 86, 87 people that are waiting for a bed at Galen to have their initial evaluation. Some portion of those may either be determined that no, they are currently fit to proceed, or may require only very limited services to be restored. If you could begin to carve out those numbers, you're at least seeing what you're dealing with. The other thing a local evaluation would tell you and could help with is prioritizing the people who really do need to get to Galen quickly because of their acute circumstances. So local mental health or local forensic evaluations, court-ordered evaluations uh, would streamline the system and at least make that first initial cut to help reduce those numbers or prioritize the people that need to get to Galen. Beyond that, there are other issues of which there is room for debate. Is jail the best place for someone to be restored? Is it really a properly therapeutic setting to generate the care and treatment that would allow someone to be restored in their jail setting, that could also then mean they do not have to go to Galen. It is a bed space saved for someone else that can go and be evaluated and restored at Galen. But these are all issues that show how the criminal justice system and jail or detention facilities, which are already overwhelmed. There was report today that I saw about the Yellowstone County Detention Center and the courts working on a new arraignment process to where they can have hearings more quickly in front of justices of the peace to see if bail is possible to reduce some of the pressure on the Yellowstone County facility. I'm sure that the larger detention facilities across the state are looking at things similar to that, but they are, like the state hospital, filled to the brim. There is no more room. And on top of that, they have many detainees, inmates that need mental health services that they simply are not equipped to deal with. Again, if you could prevent people from getting to jail in the first place, so many people commit their crimes as a result of either being lost on the streets, uh, oftentimes misdemeanors, sometimes felonies, sometimes due as a direct result to their mental illness. If there is a way, again, you hear that term, divert them. If they could have gotten mental health care earlier, we might have prevented them from being in the criminal justice system. So again, it's not just what's happening at Montana State Hospital. It's not just what's happening in the jails. It's what's happening outside in the communities, and what uh, safety nets, what safeguards, what barriers can we set up through which people can get health care, mental health care that prevents them from being forced into the criminal justice system. It's all essentially the same problem, the same issues. We need more services in the community, which is going to require attracting strong workforce and requiring the state to provide the incentives to providers and caregivers so that these services can be found and requirements met for this ever burgeoning population of people, both with substance use issues as well as serious mental illness. So that's the hospital. Those are the kind of the three main segments. And as you can see, we want to prevent people from going there in the first place. Obviously want them to be as treated as well, and for their treatment to be as positive and beneficial for them. But also when they get out, we want discharge to be better. Case management services can help with that. Navigators can help with that within the state system, who can make sure that people are set up as well as possible, perhaps to get on waivers, to get ensure they're getting Social Security benefits, um, to find ways that they can get into funded services as quickly as possible, and that those things can be arranged before they go, rather than have the individuals themselves attempting to navigate these incredibly complex delivery system and funding mechanisms, and filling out forms that are would be complicated for any of us. But the expectation is that people transitioning from the state hospital should be able to do a lot of those things on their own. It's asking too much, and it's asking for problems down the road. So all of these services, the continuum of care, uh, case management, targeted case management, transition case management, transition planning, but finding a workforce that can fill all those roles is going to be absolutely essential going forward. There's a few things that I did want to talk about, and I realize time is ending, and I don't want to belabor some of these things. But what in researching for this and just generally looking at things, I mentioned the 2020 report on the geropsychiatric facility at the State Hospital, which, as I say, talked about some of the problems that could arise at Spratt, talked about staffing issues, the importance of discharge planning, and a much more concerted effort to work on discharge out of the Spratt unit. It was prescient in many regards, and uh, everything that was said in 2020 in this report remains true to this day. In 2016, the Montana Healthcare Foundation um, had a report, and there are some things. I'm just going to click some things off. I think you'll see where I'm going with them as I go through these things. But again, in 2016, this Montana Healthcare Foundation report talked about the hospital was operating at maximum capacity in 15 of 17 last months. Of the last 17 months, the state hospital exceeded its capacity of 208 licensed bed. There was not a single month from July 2014 to November of 2015 that the hospital operated at under 96% of its total capacity. This report went on to talk about the fragmentation within the system, lack of communication, kind of the lack of one-stop shopping, as it were, to get behavioral health services. Um, it also, again, this is in 2016, where it stated that Montana's justice system serves as a de facto behavioral health system, and also noting the relatively high cost for individuals who are incarcerated with behavioral health concerns. Again, this is 2016. Um, the problem was recognized there. Uh, the complexity of the behavioral health system, as I noted, the fragmentation, the separate administration, funding, and service provision continues to be a problem, something that had to be addressed. Um, and again, when you get to the health workforce, this report noted the Kaiser Family Foundation estimates that only 25% of Montana's mental health care professional need is met, placing it in the bottom five of all states. And it further talked about that between 75 and 80% of the professional people were in just 8 counties in Montana, meaning that you have mental health care deserts essentially throughout much of the rest of the state. In 2013, the Department of Public Health and Human Services and the state hospital uh, provided a report which it's also fascinating to me as you look into these issues because things that they are saying in 2013, 12 years ago, are exactly the same things that we're talking about today. When they're talking about current trends and problems, they recognize increasing demand for inpatient psychiatric treatment, shortage of psychiatrists in Montana, increasing demand for forensic inpatient services, what we were just talking about with Galen. What they saw even in 2013 was the decreasing availability of community-based mental health services, particularly in certain regions. Um, Also, they noted in 2013, uh, recognized the increasing demand for managing behavioral issues of patients diagnosed with dementia and Alzheimer's. They talked about barriers to discharge. When I was talking about Category D facilities or the difficulties in finding placement for people currently at the Spratt unit and the difficulties in finding placement for people who are in the regular units at the state hospital. um, 2013, there are no community or mental health providers uh, with the incentive to accept patients or provide care. Again, that word incentive, incentivizing people. If you want people to provide this kind of care, you have to give them the assurance that it will be worth their while, that they will be able to build the necessary facilities, that they will be able to pay for staff, that they will be able to provide the specialized care necessary. They have to have assurances from the state. They have to know that if I get into this line, that there is a business model that is sustainable. And to date, as we have seen, those incentives just are not there yet. Um, Basically, and they're talking about simply limitations on funding that's not acceptable to community providers, um, lack of group home residential services for those in recovery in most communities, long waiting lists for psychiatric services in communities, and long waiting lists for case management services. Um, just the number of community treatment challenges was endless. Um, so all of these things really, you go back to 2013 and the basic fundamental challenges that the hospital saw in both discharge and caring for patients and trying to prevent patients from getting there in the first place was again lack of recruitment and retaining treatment providers in rural and remote locations, the difficulties in managing the needs of individuals with increasingly complex medical problems, which is the Spratt unit to a T. You have people with behavioral issues, neurocognitive disorders, and sometimes very significant health problems. And then you add on top of that a rising level of people with uh, drug-induced mental issues and substance abuse issues, and you just added a whole nother layer of complexity to these issues. Um, and even back in 2013, the hospital recognized that, we really need to develop an electronic medical record system here. We don't have one. Lo and behold, in 2025, we are still working on developing one, which makes our state psychiatric hospital one of the lone ones, perhaps in the nation, that still does not have an electronic medical record system set up. There was another, and I may begin to kind of beat you about the head and shoulders with this, but in a 2008 report to the legislature, um, they were talking about this was the DMA Health Strategies report in 2008. They talked about, again, lack of services in the community, the need for more recruitment, the use of telehealth, the need to bring in more psychiatrists and to sort of disperse the services through telehealth of these limited number of psychiatrists across the state. Um, One of the interesting things that they talked about, again, this is 2008, just like CMS said in 2022, this report said we perhaps need to consider legislation that enables Montana State Hospital to refuse admission for individuals that can be safely and appropriately served elsewhere as crisis capacity is developed. It is the exact same refrain that we are hearing now, that much of the next generations is about. We don't have the infrastructure to prevent people from having to be committed to the hospital. We need to do it. Hospital's overwhelmed. Everybody knows where to do it, how to do it, but we simply have not put it all together yet. One of the things they also talked about, which was very important, was they recognized that discharge services at MSH, uh, there needed to be more effort put in there. There needed to be ways to measure both MSH and provider performance in the participation of the process. They thought it was absolutely essential that providers be able to visit the hospital to meet the people that they might be welcoming through the discharge process, that it was so important that the providers should be compensated for this, for their travel, that it should be something on a regular basis. And especially when you had hard to place individuals, that you really needed to make it a person to person event. And that until that happened, discharge from the hospital would continue to be uh, very, very difficult. Um, Finally, and the last one that I'll leave you, I know we're going a little bit over time, but one of the most fascinating things I came across is goes all the way back to 1975. And this report, it's really a booklet, and it's fascinating for a number of reasons. It's called An Inside Look at One of Your Institutions, and it was written and published by the employees of Montana State Hospital back in 1975. And I will spend a little time of this because uh, it is so filled, it is so much irony uh, and I don't want to say humor, but it's I don't know whether it's humorous or disturbing that the issues that they were talking about 50 years ago are so close to the issues that we're talking about today. And so I guess the main point I'm trying to make here is none of this snuck up on us. This is not something that we suddenly realize, oh my God, we've got a crisis on our hands. This is something that people have been thinking about and have recognized solutions for 50 years. But one of the most ironic things here is that 50 years ago, one of the things that the employees were most concerned about was that the Warm Springs State Hospital was not accredited by the Joint Commission on Accreditation of Hospitals. In other words, they were not accredited. 50 years later, we find ourselves in the same situation as a hospital is once again essentially not accredited, or at least not through CMS. But one of the things they were hoping for was that once accreditation occurred and they could get Medicaid funding and they would have doors open for more federal funding and programs, that they thought many of their problems would be solved, that with accreditation would come easier recruitment and retention. That certainly hasn't happened. But again, it is quite ironic that 50 years later, we are finding ourselves in a very similar situation. One of the things that they talked about also, if 50 years ago, was the pre-release program and how important it was and what was lacking currently at the hospital and needed to be developed. Was more occupational training, rehabilitative services. They wanted kind of a step down in the hospital itself where people who were getting ready to be released could be together. They could have job training, people training, communications training, and really get ready to go out into the world. And one of the things they talked about even then was the necessity that they begin to make contacts with providers, potential employers before they left the hospital. So that was recognized as something that was needed. And unfortunately, at different times in the hospital's past, they've done more of that. Those are not necessarily things that are being done now. Um, in final, one of their sort of closing statement is the current situation at the hospital could be characterized as one of an institutional identity crisis. Under present circumstances, morale is extremely and predictably low. Poor salary offerings make recruitment and retention of qualified staff very difficult. Persistent doubt about the future of the hospital is having a seriously adverse effect upon staff recruitment. Turnover rate for the hospital staff is well over 60%. Gains made are eroded almost immediately by the atmosphere of futility and uncertainty which hangs over the institution. Things that at least a few years ago you could have said are exactly the same. I think things perhaps have improved some at the hospital, but certainly many of the same feelings there um, were feelings as far back as 1975. So with that, I will close. Um, I realize this isn't really a statistically based. There, I was trying not to throw a whole lot of numbers at you, but I did want to give people who may not be familiar with the state hospital, again, this bird's eye view of things and show kind of how things cut across the board, that we have these same themes whether at the legislature or in the press. We continue to face the same problems that we have in the past. I think that was the last thing that I wanted to emphasize is this is a generational thing. You can go back literally exactly 50 years ago and find people recognizing the exact same problems, having the exact same concerns about mental health care delivery system in Montana and specifically at the hospital. So with that, I will close and we look forward as these things go on. We are thinking of other topics to talk about as the legislature goes on. I'm sure there will be other topics specifically addressing some of the legislation that is currently proposed that we can talk about. Um, there are other programs and priorities here at Disability Rights Montana that can serve as topics. Um, but it is a dynamic, ever fluid situation. But as we can see, the clock has run out on us. You can't address these same issues and fail for 50 years and expect now that we literally have no capacity in any of our institutions. You now have our jail and detention facilities completely overburdened, and you still have the same general lack of care available in communities. It's insurmountable. And so I hope that in the end, we can do more than simply look back and say, those folks from CMS that came up from Denver, wherever they were right. We simply have systemic flaws built into our system that we cannot overcome. And now we have a full blown crisis. And we have no place to turn. We're too late. We've simply acted too late. I am hoping that with all the work, extensive, great work that was done in the 2023 session, the work that's been done with the 872 Commission through interim committees and legislation being proposed now, that finally we begin to get ahead of these issues. We can become more of a community based delivery system, and that some of these possibly insurmountable problems we begin to get ahead of. So thank you for the time and
Thank you,
attention,
Mike.
and we'll go from there.
Thank you very much, Mike. And for those that were here, I was posting a lot of information in the chat as Mike was talking about specific documents, things he was mentioning. If you're listening to this asynchronously or watching it, a recording of this, there'll be a link somewhere where you're watching this that'll point you to the direction of a lot of these reports, laws, and 872 Commission, CMS letters, all those things that were mentioned tonight. Thanks for being here, and we'll see you all on the next one. Bye.
Good night.